Right, it's sharp 7. So very good evening, everybody. So I welcome you all to the 9th webinar organized by the Sri Lanka College of Internal Medicine Medical Students Forum. So as I always tell you that we named this forum Future because we firmly believe that you medical students are the future of the country. So the Future, the Medical Students Forum, aims to empower the students with essential knowledge and skills in approaching common clinical problems. So our theme for the year 2023 is to enrich clinical competence with compassionate care. So this is one of the important activities to achieve this theme. So today also, we are going to listen to a very important and a very practical topic discussed by an astute clinician. So before we start, few housekeeping rules as usual. So please keep your mics mute and camera switched off to avoid any disruption. And in the end, there will be a Q&A session, and you are welcome to ask any questions in the chat box. And then I will post a link in the chat box for a feedback form, and this will be posted in your WhatsApp group as well as in your Telegram group. So please be kind enough to give us a feedback because it will greatly help us to improve this activity. And please note that there will be a live broadcast on the Sri Lanka College of Internal Medicine channel on YouTube and the Facebook channel. So the next item is to introduce the speaker of the day. So may I invite Dr. Dhammika Palingasinghe, specialist in internal medicine and a senior lecturer in medicine, representing the faculty. I mean, he's the faculty representative of University of Ruhuna, to introduce the speaker of the day. Over to you, Dr. Dhammika.
Thank you, Jamara. So good evening to all of you again. And it's my privilege and pleasure to introduce today's speaker, Professor Arosha Dissanayake, Professor in Medicine and Consultant Physician from Department of Medicine, Faculty of Medicine, University of Ruhuna. I think this forum need no additional introductions to Professor Arosha Dissanayake. It's my real privilege to see you, sir, and thank you very much on behalf of Sri Lankan College of Internal Medicine in accepting our invitation to share your valuable time with future junior doctors of this country. And I think it will be a very valuable and a wonderful session for all of you to listen to him during this 1 hour or so. I know Professor Arosha Dissanayake for the last 15 years or so, since a time of medical student. And even today as a physician, I enjoy listening to his clinical teaching. I think he is an eminent physician and a brilliant clinical teacher I have seen all over the many years, and he's a very respected teacher and a role model for many medical students, junior doctors, as well as physicians, especially junior physicians as myself. So without taking much time from you, I would invite you, sir, to share your clinical experience and make cranial nerve examination simplified and give this valuable opportunity for the medical students today. Over to you, sir.
Right. Thank you very much, Dhammika, for that very kind words of introduction. I hope you can hear me. Are you hearing me all right?
Yes, yes, sir, we can hear you very clearly.
That's so. First of all, may I thank the Sri Lanka College of Internal Medicine, the President, Dr. Kumudini Jayasinghe, and the Council for inviting me to speak at this very useful forum called the Future. And also special thanks to Dr. Chamara for taking a lot of trouble in organizing this. And of course, a very pleasant surprise to be introduced by Dr. Dhammika Palingasinghe, who is my very dear friend and colleague from the Department of Medicine. So I will try to share my screen with you, and thereafter we will try to have the presentation going. And if at any time you don't hear me or the presentation disappears from sight, you must tell me so that I can sort that problem out. Okay, just give me a second. Right, okay. Again, Chamara, you're hearing me okay? You're seeing the slides good, right?
Yes, sir. We are hearing you okay, and right. Slides are very clear, sir.
Okay. Right. Now, as a medical student, when I was a medical student, I had two objectives, and I I believe that the objectives have remained the same over the past 30 years or whatever. One is, of course, to pass this terrible exam called the final MBBS exam, which is looming ahead of us. That is objective number one. Objective number two is to become a good doctor who can actually find what is wrong with patients, make diagnosis, and treat and make patients feel better. Well, those are twin objectives. And so this exercise today is primarily aimed at helping you to pass the exam. Then, of course, with this knowledge, you can certainly become a good doctor. Now, I'm a little nervous always about trying to teach medical students from, say, other faculties also, because it is quite possible that your teachers have taught you this better than I'm going to teach you today. If so, apologies to your teachers and bear with me. I'll try to do justice to this topic. Right. Okay. Now, a slide very briefly to tell you at the short cases, how are the marks distributed? Now, before that, why am I particularly choosing short cases? That is because now you all, I'm sure when the exam gets near, you all do MCQs, discuss MCQs with people. You all, read previous answers to SCQs. So all of that is prepared. You get good preparation for that. Then, of course, long case preparation happens every day in the ward. The consultant stands near the patient and asks this dreaded question: whose patient is this? Sending shivers down everybody's spine. And anyway, you present the story. So that's long case training for you. And then you'll do that by every day you take history. So all of that is long case preparation. But compared to all three other components in the exam, when you look at the short cases, you get hardly any preparation at all. And mind you, from the clinicals, you need to get 50%. And it is unusual for somebody who has done a reasonable amount of work to fail the long case. Just about everybody passes the long case. So if somebody does come down in the exam, the clinical component, invariably it is during the short cases. So the short cases, you will have 4 short cases and an aggregate of, I think, roughly about 20% of, it will be about 20% of the marks of the entire final exam. So one of those short cases will carry full 5 marks each short case. So short cases are very important because we prepare least for short cases. And then I hope this exercise will help you. And also, I want you to understand that short case preparation has to be done at the bedside. That is true. But a lot of thinking has to go into how you're going to handle a short case. Now, that is what I'm going to look at today, to prepare you mentally how to do a short case so that you know exactly what to do and what to expect when you stand near the patient. So coming back to this slide, what's the distribution of marks? Now, you get about 7 minutes. I'm sure there might be slight variations in different faculties, roughly about 7 minutes for a short case. After 4 minutes of examination, the teacher will tell you in a very rough voice, 1 minute left. And then, of course, you've got to finish in the remaining 1 minute. Maximum you will be permitted will be 5 minutes. And after that, they will stop you and start question. Now, for 2 minutes, the examiners will question you. If you look at the distribution of the marks, there are marks roughly about 30% out of the marks allocated for each short case, which will go to examination technique. Now, technique, remember, has 2 components. One is you need to check all items in the examination. You have to do everything. You can't miss anything. And then, of course, what you do has to be in the correct technique. So there are 2 aspects which are being evaluated there, all items and correct technique. For instance, I will tell you, if you go on the left side of the patient and examine all things in the cardiovascular system, obviously somebody will say that's not correct technique. So you will lose some marks there, even if you check all items. At the same time, if you go on the correct side and have a brilliant technique, but you don't auscultate the heart, well, you don't again get full marks because all items have not been done. So remember, these 2 have to be done, all items and correct technique. Now, these 30 marks are entirely in your control. That's what you must remember, because actually you can get all 30 marks. It's what you do there, and you can prepare amply for this, and no one can take away marks from you on that. So that's 30 marks. Of course, the next 2 minutes brings you roughly about 70 marks. One is the examiners will ask you what the physical signs you detected were. You'll be asked to present your findings, and among the presentation, in the presentation, you will have to list the physical signs that you found. And then they will discuss the physical signs to see, what is the likely diagnosis, what's the differential diagnosis. Somebody can ask you what's the most important investigations to do in this patient, etc. A discussion, which again will take about 30 marks. And finally, 10 marks are generally allocated for the general approach that the student has, including, the voice has to be audible. Audibility will take some marks. How confident you are in presenting, whether there is clarity in what you say, whether what you're saying is clear, confident, audible, and of course, how you tackle the patient, because remember, the examiner is watching you, and if you've been rough with the patient, they may give less marks, but for somebody who is very gentle with the patient and who is respectful to the patient will get 10 marks. Now, why I put this slide is just to draw your importance. Now, this slide applies to every single short case, not just the neurology. Now, what I want to highlight here is for 5 minutes, you earn 30 minutes, and for 2 minutes, you earn 70 marks, right? For 5 minutes, 30 marks, for for the remaining 70 marks in another 2 minutes. Now, so the last 2 minutes becomes really hectic, and you got to brilliantly perform to collect as many marks as possible. Now, the obvious way of actually making this very difficult task a bit early is for you to finish your examination by about 4 minutes, so that you get 3 full minutes to earn the 70 marks. 3 full minutes. So if you can train yourself in terms of examination technique, how to carry out a complete, correct examination within 4 minutes, then you can use entire 3 minutes to earn the 70 marks. As you would appreciate, until you start talking, which is once you finish the examination, the maximum, even if Dr. Chamara was to examine, all he would get would be 30 marks, nothing more than that. Rest of the 70 will be only when he starts speaking. So however brilliant the doctor is, they will not be able to earn more than 30 marks in 5 minutes. So just to show you how important it is to practice, so that you can finish in about 4 minutes, so that you leave about 3 minutes to gather 70 marks. Right, now that it's out of the way, again, something related to neurology, which is not directly part of the topic, I want you to understand this as well. Now, when you are practicing, I'm sure you practice cardiovascular, you practice abdomen, you practice respiratory. So that's just 3 systems that you got to practice. But in neurology, within neurology, there are 3 systems embedded. You can't do one protocol and be fully versant with neurology, because neurology, within one short case on neurology, there are 3 short cases. One is face examination, which I'm going to do today, upper limbs examination, and lower limbs examination. Now, these are vastly different, and in no patient will you be asked to do a full neurological examination. Your question will invariably be either face, upper limbs, or lower limbs. Now, about a year ago for the SLMA Saturday talk, I did lower limbs. I don't know whether that video is available. I did a Zoom one. If you can get hold of that, you can listen to me speaking about lower limb examination. But for today, I'm going to talk to you about face examination, and maybe on a later day, somebody else can cover upper limbs and lower limbs. Right. Now, this might look very basic to you, but it's important at times when students are questioned, at times they get a bit clustered. I mean, all cranial nerves starts from the brainstem. Brainstem is within the cranial cavity, and all the 3 parts are the midbrain, pons, and medulla. Roughly, the first 4 comes from the midbrain. Roughly, the next 4 will come from the pons, and roughly the last 4 will come from the medulla. And all of these nerves will have some course within the cranial cavity before exiting from various foramina, which have horrible names, which none of us can remember. But there is a course always within the brainstem. So this is a very basic bit of knowledge which you must keep in mind. Right. Now, when you come to when you get a patient who has an abnormality in the face, there are several commands which the examiner might give you. He might say, examine the upper or lower cranial nerves. Immediately, it must cross your mind what you need to do. Or the examiner might say, examine the motor cranial nerves. Or the examiner might say, examine the eyes. Or inspect the face and proceed. Or a very difficult command, speak to the patient and proceed. So these are roughly the 5 or 6 commands that somebody can give you when face is being examined or cranial nerves are being examined. I mean, it's not exhaustive. So if you set your mind, there are only 6 things that the examiner can ask me, then you're okay. First one, you might be told, examine the upper cranial nerves. Immediately you must have practiced knowing what to do. First thing is, you know that the first cranial nerve is not done in exams. There's a typo there. First cranial nerve is not examined at exam. So though the examiner says examine the upper cranial nerves, we are talking about 5 cranial nerves. Out of the 5, 2, 3, 4, and 6 have something to do with eyes, right? Eyes. So you need to examine the eyes, and then of course the 5th nerve has been left behind, the trigeminal nerve. If it's upper cranial nerves, all cranial nerves, you need to check for the motor, the sensory, and if there are any reflexes associated with it, you might have to do that. So you might want to do get the patient to clench the teeth, then of course check the jaw jerk, check for not the corneal reflex. There is again before this examination of the sensory of the face, ophthalmic, maxillary, and mandibular parts. Then of course you can tell the examiner you'd like to examine for the corneal reflex. So that's the kind of thing that you might want to do if it's examination of the upper cranial nerves. Now, next slide is important. Now, you might also get, as I told you, examine the eyes. Now, again, related to what we did earlier. Now, though upper cranial nerves 2, 3, 4, 6 examine the eye, we never check for 2, 3, 4, 6, like we would check for, shall we say, 5, 7, 8, 9, 10, 11, 12. There are very specific maneuvers which we do for each cranial nerve. So you must get out of the mindset where we are going to examine 2, 3, 4, 6, but replace that with something called examination of the eyes. Examination of the eyes. I hope you understood what I'm trying to say. Now, 7 is very clear, you know what to do. 8, very clear, you know what to do. 9 and 10, you know what to do. 11, you know what to do. 12, you know what to do. But 2, 3, 4, 6, you don't check individual nerves. You replace that or substitute that with something called examination of the eye, which in turn has 6 components. Now, this is what I've written here. This is how you would check the eyes. So we'll cover the examination of the eyes here. The 6 parts are, I don't know, you must develop some way of remembering it in this order. If you all can think of a good mnemonic, I've been trying to remember to design a mnemonic for the past so many years, but I have not been able to. So if you all can think of a nice mnemonic, I'll be very happy to hear from you. But it's something like IPA, FMF, IPA, FMF. You need to, when you're examining the eyes, you need to inspect the eyes from in front of the patient. And you might see either a ptosis, where the eye is partially or fully closed, or you might see an open eye, which is not blinking, unblinking eye, or you might see a squint. So these are the 3 things you will look for when you inspect the eyes. Inspect the eyes. Is there a ptosis? Is there absence of blinking and a fully open eye? Is there a squint? Obvious squint. Then we get down to pupils, P. Now pupils, you don't take part of as part of the inspection, you do a separate pupillary examination. And we need to look for the pupillary size, then direct and consensual light reflex, direct and consensual. And there is something called relative afferent pupillary defect. I will not try to explain that here. We'll leave it aside. If we have time, we might come back and look at that. But what a relative afferent pupillary defect tells you is that that eye is blind. You know, that eye is not carrying visual impulses. It can be a long-term blindness of the eye, or it can be something like an optic neuritis or a retrobulbar neuritis, which will cause a relative afferent pupillary defect. If we have time, we'll look at that, but don't worry too much about it. For the time being, if you can look at the size and look at the reflex, that should be sufficient as examination of the eyes. The third thing, IPA, is visual acuity. Now, you don't have to carry a Snellen's chart, but you need to check the patient's vision, whether the patient can see. Because what will happen is, if you don't check that and try to look at fields and movements, if the patient cannot see with the eye, then he will struggle. Then and you might think that it's a visual field defect when it is actually due to a loss of acuity. So how do you do acuity? You need to just, I mean, I think a reasonable thing would be to just get them to count fingers by each eye separately, not both eyes together. Just close one eye, ask them, you know, show them 3 fingers or so. Can you identify my fingers? How many are there? And do the other side also. That's for a short case, for a rapid short case, which you're trying to finish in 4 minutes. I think that's be reasonable, just to show that you are checking acuity and that the patient is not blind actually. So IPA is over. Then of course you will examine the visual fields. Fields, you know that you know the technique, confrontation technique with the patient. You sit in front of the patient and of course examine the visual fields of the eyes again separate. Just like acuity, we will check fields separately, because otherwise if you can't check both together. And then of course next you need to look for eye movements. Now eye movements, again you will check eye movements with both eyes at the same time. And then when you will take as prescribed in the examination textbook, you will check whether the patient's both eyes move together. Of course, you must remember that if the patient has a mild paralysis of the ophthalmic muscles, what's called a mild ophthalmoplegia, then you may not be able to see that there is a squint or there is a lag in eye moving, but patient may complain of double vision. So when you go to the left side or right side, you must always ask the patient, do you see one image or do you see 2 images? So if there are 2 images being seen, that tells you that the patient has an ophthalmoplegia, even though it doesn't look like that to you, right? If there's a massive, big ophthalmoplegia, you will see the squint, and of course the patient will say there is double vision. But it is mild degrees, the patient will only have double vision. So it's important to always ask those 2 components. You get the fingers there, ask the patient, you tell me when, you know, and follow the finger with the eyes. And when you go to the extreme, you ask for two images. Then of course, finally, it's fundus, optic fundus. In the short case, it is very unlikely that you will be asked to examine the optic fundus. It would be very, very unusual for a candidate to be asked because we just don't have the time. But if you are going to become, from a doctor point of view, of course, examination of the fundus is important to look at both the optic disc and then the surrounding red parts of the retina. But usually fundus is not checked, but you must turn to the examiner and say, I would like to examine the fundus to complete the eye examination. So this is the examination of the eyes. So it goes as IPA, FI for fields, movements, and FU for fundus. IPA, FIM, FU, FIMFU. IPA, FIMFU, this is the examination of the eyes. Now I'm going to go back to the earlier slide. If you are asked to examine the upper cranial nerves, all you do is straight away go for, we know that we don't do one. So always straight away you go for the 6 things associated with the eyes. That is inspection, for ptosis, for non-blinking eye, and for a squint. Then pupils, the size and the direct and consensual light reflexes. Then visual acuity, counting fingers, each eye separately. Then fields, again, each eye separately. And then movements, where we are going to look at whether there's a squint appearing when the eyes are moved, and also checking double vision. And then finally offering to check the fundus. So you do that, and then of course you come back to 5 and do the clenching of the teeth and the sensory part, sensory examination of the face and all that. Now, just a little point, when you're examining the sensory component of the trigeminal, I've seen students actually use a pin prick on the forehead, and then ask whether the patient is feeling the same in the rest of the face. You must remember, even the forehead can get affected if it's trigeminal nerve which is defective. So again, now come back to the protocol. Very simple. If you get somebody with, if the examiner says examine the upper cranial nerves, very quickly you do the eye examination, IPA, FMF, and then do the trigeminal nerve, and your work is over. Right. This is the eye examination of the eyes. And then, of course, the second command, third command, we've examined 2 above. The third command you can get is examine the lower cranial nerves. Now, lower cranial nerves, again, you must train yourself very quickly. What are the things I have to do? So lower cranial nerves, again, as I told you, every time you think about what is the motor, what is the sensory, and what is the reflex. So lower cranial nerves start from 7. When you're checking motor of 7, very quickly do 4 things. Ask the patient to screw the eyes up tightly, try to open that. Ask them to screw up the forehead. Ask them to show their teeth and blow the cheeks. So 4 things to be done. Immediately you check the motor. And of course, 7th nerve has sensory function as well. Sensory, it's interesting what the 7th nerve sensory is. It's inside the oral cavity, but we don't do sensory in the short cases. And then, of course, corneal reflex, part of that comes from the 7th nerve, but we don't do corneal reflex in the exam again, because doing corneal reflex by 30 students, patient will be blind by the time they finish. So remember, motor, we will only do the 7th nerve will only do the motor, but of course, tell the examiner that it will be complete only if we can actually do the corneal reflex. And then, of course, 8, what we do is you just whisper a number in one ear, keeping the other ear closed. Do that. And then 9 and 10 together, just look at the palatal movements. We don't do gag reflex in short cases. We don't test for, taste and all that in the short cases. So 9 and 10 together, and 11 will be neck and shoulder movements, and 12 will be tongue movements. 2 movements in the sense, getting the patient to stick the tongue out, move sideways, and then to see whether the tongue is weak, ask the patient to press the tongue. I'm sorry, the tongue spelling is wrong here. The tongue against the cheek. So though we feel, if somebody were to suddenly examine the lower cranial nerves, it might look daunting. It is not. So remember, always remember where you're going to start. When you do the first maneuver, immediately everything else falls into place. So if you ask lower cranial nerves, start straight away asking the patient to close the eyes tightly, and then try to open that. Get them to wrinkle the forehead, show teeth, blow cheeks, whisper in each ear, check the palate, whether the palate is moving, whether the palate is drawn to a side or whether the palate is moving normally, and then get the patient to turn the head against resistance on the chin, shrug the shoulders, and check the tongue, stick the tongue out, turn the tongue sideways, and then push the fingers with the tongue inside the cheek. So if you actually really think about it, now let's look at this. I'm sure, though it sounds very daunting, if you really think about it, to do these 5 things, I don't think you will need even 2 minutes. So if you are well trained, you can examine the lower cranial nerves within 2 to 3 minutes. Not a problem at all. Even if you take 4 minutes, it doesn't matter. So very quickly, even the examination of the eyes, if your command is examine the eyes, I mean, to do these 6 things, I'm sure you can do within 2 to 3 minutes if you are well trained. Though you might feel a bit lost when you're told to examine the eye. So again, remember where to start. The place to start is inspecting the eyes for ptosis, non-blinking eye, and a squint. And if somebody was to say examine the upper cranial nerves, again, you might find it very daunting, but don't worry. You know that the place to start will be the eyes. Again, starting with inspection of ptosis, non-blinking eye and squint. So though these commands can actually frighten an undergraduate or even a postgraduate, when you are really focused on it and when you have thought beforehand what you have to do, actually, it becomes very simple. So upper cranial nerves, eyes, lower cranial nerves. And then, of course, somebody can ask you, the next command that somebody can give you is examine the motor cranial nerves. You must immediately know how to do the motor cranial examination. Okay, sorry about that. Motor cranial nerve examination. Again, start with the eyes. Here, though optic nerve is not part of the motor cranial examination, to do a proper eye examination, like eye movements, you need to assess somebody's vision. So there is no exception. You do the examination of the eye, the 6 steps, and then you've covered 3, 4, 6, and then come back to 5. You know what to do with the 5 motor, so don't worry about the reflexes or sensory. Then 7, the 4 things to do with the 7, 9 and 10 together, 1 thing only the palate, 11 neck and shoulder, 2 things to do, and 12 tongue, 3 things to do with the tongue. Stick the tongue out, move the tongue sideways, take the tongue in and push against the cheek against resistance. So 3 things with the tongue. So again, if you are told examine the motor cranial nerves, you must know what to do and do very quickly. And if you really look at this, I think you can quite confidently finish them in 3 minutes. I'm sure you can finish in 3 minutes. So you take 1 minute extra, you finish in 4 minutes. Now, this is a bit of a tricky command. Examiners have a habit of telling you at times to do this. Inspect the face and proceed. Now, this is where you must think beforehand what are the possibilities so that you know what to look for. The most common short case cranial nerves or facial examination is probably a facial asymmetry with a non-blinking eye, representing a facial nerve palsy. This is probably the commonest and one of the easiest short cases you could ever get. So you might see that somebody is having an asymmetrical face, and then you look at the eye very carefully, it's not blinking. That's one possibility. The other could be a unilateral ptosis. That is also a very important and short case which you have to have thought out before. Bilateral ptosis is not common. It's very uncommon, but if there is, they can give that. Then, of course, it is the other possibilities that the patient might have a divergent squint. When you look at that, the eyes look generally normal, but there is a divergent. Eyes are looking away from each other, a divergent squint. Right. Now, let's look at the instance of a face drawn to a side. Then, of course, you inspect the eye for absence of blinking. That's very important. And loss of prominence of the nasolabial fold. Then, of course, you will confirm the weakness of the face, asking the patient to do 4 things: close the eyes tightly shut, screw up the forehead, show teeth, and blow cheeks. 4 things. Again, important here is to remind ourselves what this Bell's phenomenon is. Bell's phenomenon is when the patient cannot close the eye tightly, the eye is seen to roll up. Now, though that's called Bell's phenomenon, I've had students who come and tell me the diagnosis, the cause of the facial nerve palsy is Bell's palsy. And the reason they say that is because there is a Bell's phenomenon. So what you must remember is Bell's phenomenon will be seen in any patient with a facial nerve palsy who is unable to close the eyes tightly. Okay, so you just confirm that the patient has these things, and then also ask permission or tell the examiner that examination of the facial nerve will require that you examine for the corneal reflex, but they will never ask you to do the corneal reflex. And then, of course, you need to look for the underlying cause of the 7th nerve palsy. Now, there are only 2 reasons why somebody can get the 7th nerve palsy. An upper motor neuron facial nerve palsy will cause paralysis of the paralysis of the lower part of the face, and their foreheads are spared. The only common reason that can happen is a stroke. in which case the patient will be hemiplegic. It would be extraordinarily rare only to get a upper motor neuron facial palsy as a stroke, but invariably the patient will have upper and lower limb spasticity as well. So if your patient is unable to wrinkle forehead, able to wrinkle forehead very clearly, and maybe shut the eyes also fairly tight, you know that this is likely to be upper motor neuron. Then upper motor neuron, you need to look at that side arm, just tap the biceps jerk and see whether that is exaggerated. That's a stroke, and the patient has got an upper motor neuron palsy. Of course, having said that, if there is a brain stem stroke at the level of the pons, it is possible for a stroke to have spasticity on the other side. On the other side, left side, shall we say, there is a right facial palsy, there can be a left side spastic upper limbs, exaggerated jerks, and a lower motor neuron facial palsy on the opposite side. You know, that's a kind of a cross paresis that can happen if the stroke is at the brain stem level. Now, that is of course a fairly rare phenomenon, but I'm just trying to make it complete. So upper motor neuron means a stroke, and you must look for a exaggerated biceps jerk and an exaggerated ankle jerk. But more commonly, we will see a lower motor neuron facial palsy where the patient loses the ability to wrinkle the forehead, loses the ability to close the eye tightly, and the lower part of the face is also paralyzed. Patient will have saliva drooling from the corner of the mouth. Patient will not be able to show you the teeth, will not be able to blow the cheeks out. So all of that is a lower motor neuron facial palsy. That's the common one, probably the commonest short case you will get at the exam. Now, there is no point in, as an undergraduate, just saying this is a lower motor neuron facial palsy, because that is so easy. Anybody can say that, you know, with the face hanging onto a side and all that. So invariably, the examiners will want you to look for and identify the underlying cause. Now, there are facial nucleus is in the pons, and then it has a part which happens inside the skull. But what will happen is we can't look inside the skull. So what we can look for would be what happens to the nerve outside. So we will look for a scar over the mastoid region. If the patient has had mastoid surgery, it is possible that the facial nerve was damaged. Maybe we should look for scars over the parotid gland to see whether that part of the facial nerve was damaged. Maybe vesicles inside the ear, looking for a Ramsay-Hunt syndrome, and also exaggerated reflexes on either side, because if it is on the same side, it is more likely to be upper motor neuron facial palsy, and if it's on the other side, exaggerated reflexes on the non-affected side of the face, then it is likely to be a brainstem stroke. So you must always, you can't stop diagnosing lower motor neuron facial palsy. I mean, you will pass most probably if your examination technique is correct, but you need to confidently say, I looked for these as the underlying cause. I couldn't find any of them. So I think this is a Bell's palsy, which is like unexplained lower motor neuron facial palsy. People think it could be viral origin. Nobody really knows. So Bell's is a diagnosis of exclusion. Right. So so we finished. Now I'll put this is so the command was inspect the face and proceed. We finished the first one, facial asymmetry with a non-blinking eye. Right. Next we have a unilateral ptosis. A unilateral ptosis. I mean, if you read the book, there will be so many causes, but remember 2 causes only for the unilateral ptosis. Is it a Horner syndrome or is it a third nerve palsy? And what do you do if a patient has ptosis? Immediately, what do? You go back to our wonderful protocol we developed in examination of the eyes, the IPA-FMF. So eye is inspect. Now you see a ptosis. So immediately when you see the ptosis, you open the closed eye and look to see whether there is a divergent squint. If there is a ptosis and a divergent squint, you know that it is likely to be a third nerve palsy. If there is ptosis and no squint, it could be Horner's or it could be a mild form of third nerve palsy, right? So critically important, In the inspection, you open the closed eye and look to see whether there is a squint. Next is the pupil. Now, I told you we need for two things, the pupil size and the reaction. So if the size is small, I mean, I always remember Horner's has a horror pupil, you know, small pupil. Then if the pupil is smaller than the other side, it's likely to be Horner's. If it is normal, it could be third nerve, it could be dilated, then it's still third nerve. So Horner's will be small, third nerve can be normal or dilated. Now, this people try to bring in the surgical third nerve and medical third nerve business. What they're trying to say is, if it's a dilated pupil, it is likely to be a surgical third nerve. Surgical means that the patient will need a surgical intervention if the pupil is dilated. The reason, the classic reason that people quote is an aneurysm of the anterior communicating, the posterior communicating, I'm sorry, it's a posterior communicating artery aneurysm. It should be a communicating artery aneurysm, which presses on the sympathetic fibers which travel on the outer surface of the third nerve. And when those sympathetic nerves get pressed, the pupil will dilate. So that is it's a dilated, it's a parasympathetic, and then so dilated pupil is with when there is a compression of the nerve. When the compression of the nerve, there is a dilated pupil, and that's called a surgical third. Medical third nerve is when the inner nerve is diseased. There is no compression. That can happen with diabetes or vasculitis. So the parasympathetic fibers are spared. They are working, parasympathetic fibers are working normally in medical third nerve and occurs due secondary to things like diabetes and vasculitis. So the size of the pupil needs to be sorted out. Remember, small pupil means Horner's, normal pupil means medical third nerve palsy, enlarged pupil means surgical third nerve palsy. Surgical means a surgical intervention is required, most likely due to an aneurysm compressing the third nerve. The reaction will be normal. Reaction in a Horner's syndrome, the reaction of the nerve will be, the pupil will be normal in a Horner's. But of course, there can be dilated pupils with surgical third nerve. Then of course, visual acuity will be normal. Fields will be normal. In the movements, in third nerve palsy, in Horner's, there is no ophthalmoplegia, but in a third nerve palsy, there can be a divergent squint. There can be a squint. So you have only the lateral rectus muscle working freely. There will be a divergent squint, and even if there is no squint, it is possible that the patient will have double vision when we are checking for the eye movements. And then of course, fundus is likely to be normal. So unilateral ptosis, the first thing is to open the pupil and check, open the ptosis and check for the pupillary size. Depending on the pupillary size, we can get an idea whether it's a Horner's or a medical or a surgical third nerve. And in addition to that, if it's a third nerve palsy, we will see a divergent squint, along with or if there is no squint, if there's mild ophthalmoplegia, there can be double vision when looking at the extremes. So this is how you will handle a unilateral ptosis. The underlying causes for third nerve, as I told you, we need to look for underlying causes. So if you're looking for diabetes, diabetes has no physical signs. Diabetes has no physical signs. There can be finger prick marks from a glucometer use. So that's a physical sign you must look for to look for diabetes mellitus. Then of course, if it's vasculitis, we very quickly look whether there are any skin rashes, joint swelling, etc. If you're looking for Horner's at the underlying cause, the classical example for Horner's is the Pancoast tumor. So you will percuss over the apex of the lung apex to see whether there is dullness there. Then of course, you will examine the patient's hands to look for clubbing. nicotine stains, unilateral small muscle wasting of the hand, and a hypertrophic pulmonary osteoarthropathy where there is pain and tenderness over the wrist. So again, coming back to ptosis, what you do is try to differentiate between the two. And then, of course, if it's Horner's, look for features of an apical bronchial carcinoma. If it's third nerve, look for features of a vasculitis or diabetes. And the physical sign in diabetes we look for will be the finger glucometer pinprick marks on the fingertips. Right. Now we go to a bilateral ptosis. Again, it's a very rare short case. The two things that you might see will be untreated myasthenia gravis or dystrophia myotonica. Again, you will, if the eyes are both closed, it's very unlikely, no one can have bilateral Horner's, or very extremely rare or ought to get bilateral third nerve. So it will be one of these two. And then we go back to the same thing. We will go back to examination of the eyes. In inspection, in myasthenia gravis, when it's not properly treated, it is possible that there is a mild squint, or more than that, we look for fatigability. That is, we ask the patient to keep the lid elevated by holding a finger above the eye. And then, of course, after some time, the fatigue will make the lid come down. Or we ask the patient to blink repeatedly, and the blinking will become slower with fatigability. Now, this is not usually coming as a short case because most of the patients with myasthenia gravis are well treated, and when they are well treated, these physical signs disappear. Now, even when there is no squint, it is possible, as I told you, a mild ophthalmoplegia might cause a double vision. So, patient may, when they're examining the eye movements, patient might complain of a double vision. That is eye, and then of course pupils will be normal, visual acuity will be normal, visual fields will be normal. We have to of course elevate the eyes and keep to check visual fields. Eye movements, there may be an ophthalmoplegia, but mostly double vision in myasthenia gravis, and the fundus will be normal. Of course, we will not be examining that. If we think it's myasthenia, we need to look for peripheral features. Very unlikely that you will get somebody with motor weakness. So the only thing that might be worthwhile examination might be a sternotomy scar for a possible thymectomy in the past, and dystrophia myotonica, characteristic facial appearance, and what's called a percussion myotonia, where you tap at the pinna eminence to see whether the muscle is going into spasm and the finger gets moved. So those are the peripheral features. If you think it's myasthenia, then you need to go for these. So these also very briefly examine this. But having said all this, I tell you again, bilateral ptosis is not a common short case. It can come, think about dystrophia myotonica and myasthenia gravis. There are rarer causes, but don't worry about those. And then of course, another difficult sorry, I just wanted to, I think I've not spoken about one here. That is, inspect the face and proceed. One thing which I have not covered is a convergent squint, which can happen in an isolated sixth nerve palsy. Sixth nerve palsy. Sixth nerve palsy, I don't have a separate slide for that. Yeah. But all I want to tell you is, again, just do our protocol. IPA FMF. So when you do that, I mean, obviously there is no, on the inspection, there will only be the ophthalmoplegia, but there will be no ptosis. Eyes will be blinking normally. Then pupils will be normal. Visual acuity will be normal. Visual, then fields may have some problem because the eye cannot move. Eye is directed elsewhere. Then eye movements will show that there is an isolated inability of the patient to move that eye laterally, showing a lateral rectus palsy that occurs due to a sixth nerve palsy. And then fundus, you will tell the examiner you would like to examine the fundus, but fundus is not examined. So when it comes to sixth nerve palsy, what are the causes, underlying cause? It has a long intracranial cause. So anything which increases intracranial pressure can cause sixth nerve palsy. That's called a pseudo or false lateralizing sign, false localizing sign to say where the lesion is. Not a false lateralizing, but a false localizing sign. That is due to any cause inside the cranium, but it can also get affected in something like diabetes or vasculitis. So we look at the fingers to see whether there are glucometer pinprick marks, and then we look for a skin rash or joint to see whether there's any evidence of vasculitis. So that's the sixth nerve palsy, isolated sixth nerve palsy. Again, ptosis, unilateral ptosis, bilateral ptosis, and open eyes with a squint. All of those, we go back to the same examination, the ICE protocol of 6 steps. Now, the speak to the patient and proceed is a bit of a tricky one. What are the possibilities? One is, of course, the patient can have some kind of a cerebellar, type of speech, but it is very unlikely that cerebellar examination you will be asked to start from the speech. So, though this can be there, I don't think it's likely. What will happen is, if somebody wants you to check cerebellar, the command will be, this patient is unsteady on the feet, do a relevant examination, and of course you will do cerebellar features. So that will be part of the lower motor neuron or upper motor neuron examination. So you are not likely to get a cerebellar problem as a cranial nerve problem, but even a nystagmus, it's possible. I'm not saying no. Nystagmus is also possible when you examine the eyes, but unlikely for a cerebellar to come as a cranial nerve examination. It is much more likely to come as a lower limb or upper limb examination case. Right. Then, of course, patient can have dysphasia, expressive, receptive, etc. So again, these are unusual things. But if it's not your lucky day, you might get something like this. So I will tell you a little story about my own final MBBS neuro short case. I tell this story because through the story, you might be able to remember some important things. So that's why I tell the story. I went for my final MBBS neurology short case. I was the last candidate of the day. So I think the examiners were also tired, and I was also quite exhausted by the time I got there. I think they had just done the routine things like examine this patient's eyes, etc. All of that had been finished. I think they were also looking for something new to do with the last candidate. So when I went to the examiner, I won't mention the names, but the examiner, a very senior teacher, he said, would you like to speak to the patient? That really caught me off guard, because I had heard that if you wanted to find the diagnosis in a short case, you had to speak to the patient when examiners were looking away. But then that is what I had heard. And when I went there, when the examiner told me, you can speak to the patient, that sounded really odd. I asked the examiner, can I ask anything from the patient? And he said, yeah, no problem. Ask anything you want. And I knew, this was some kind of trap and I was going to fall into this trap. So when I spoke to the patient, he spoke with, some kind of a dysarthria. Then immediately I was stopped and asked, okay, what's that speech defect? I said, it's a dysarthria. And then they asked me about the different types of speech problems, which I was fairly comfortable with that. Dysphonia, dysarthria, dysphasia. I spoke a little bit about that. And then they lost interest in my brilliant knowledge on this speaking difficulties. And they said, why don't you go and examine his cranial nerves? So I had prepared myself for a motor cranial nerve or upper cranial nerve or a lower cranial nerve. They said, just say cranial nerves. I asked, do I examine all? Yeah, we have, you're the last candidate. We have all the time in the world. Why don't you examine all the cranial nerves? So then I started examining. And then, of course, it was quite terrible because, second cranial nerve, I would get left side palsy or something. Third cranial nerve, bilateral palsy, like something like, fourth cranial nerve, one's the opposite side. So it was a complete haphazard cranial nerve loss. From top to bottom, I didn't obviously examine 2, but I examined everything else, and it was completely haphazard. Some cranial nerves were normal, some were left side gone, some were right side gone, some were both sides gone. And I was getting really lost. And so I asked is it all right if I write what I'm seeing? Because I knew I couldn't remember. And then I said, oh yeah, no problem. You write what you want. And then so I took a little bit of a piece of, I think my admission card, and I scribbled what happened to 2, what happened to 3, what happened to 4, etc. And then so when I finished, I had no idea what the patient had. Then they asked me, of course, I knew my examination technique was okay, but I had no, and my findings were okay, but I had no idea what the cause of this was. So then, of course, they asked me for the cause. I said it is a disease of the brainstem. They asked me which part of the brainstem. I said all 3 parts. Then said, oh, very good. So what is the cause of, what is the underlying cause of all 3 parts of the brain getting disease? So I thought for a while and said infarction. And then that amused the examiners quite a lot. So they said, oh, you mean to tell me that, all 3 parts of the brainstem are infarcted and the patient is sitting and talking to you. So I realized that, I was getting nowhere. I said, that's not possible, sir. Then I said, so can you tell us what is possible? So then I thought for a little while and very meekly kind of, in a very defeated voice said, how about a tumor? So they said, okay, a tumor which affects all 3 parts of the brainstem, midbrain, pons, medulla. There is a tumor and the patient is sitting and talking to you. I said, that is also not possible. So then they asked, oh, can you tell us something which is possible? So I said, I'm really sorry. I can't think of any reason why, any underlying cause for this. So they said, oh, I'm sorry to hear that. That's all right. You can go. So I left that place utterly dejected and depressed because I just couldn't find the cause. And actually, I graduated from Colombo Medical Faculty and I trudged along to Borella and then took a bus home, the 168. And while the bus was loading passengers in Rajagiri, I remembered what the possible diagnosis could be. And that is what I'm going to share with you. I had seen one patient before who had got several years previously, who had such haphazard cranial nerve loss. And it was a basal tuberculous meningitis that the patient had. And then, of course, the brainstem, the base of the skull, I told you at the very beginning, 3 parts of the brainstem all lie within the cranial cavity, and all cranial nerves which come out of the brainstem will travel along the base of the skull. And if there is any condition which is affecting the base of the skull, it can affect cranial nerves, and tuberculous meningitis, basal meningitis gives rise to a lot of fibrous tissue at the base of the skull. Cranial nerves get entrapped in that fibrotic tissue and then causes cranial nerve palsies. I remember this only on my way home in Rajagiriya. So following day, I met the examiner in the corridor and I asked, sir, did that patient have basal tuberculous meningitis? And he said, yes, but you are about 12 hours late in diagnosing. And subsequently, later in my life, I learned that basal metastatic deposits can also cause a similar multiple haphazard cranial nerve palsy. So I related that story so that, if you get that at the exam, if you're fortunate enough to get that kind of patient at the exam, you will do better than me and do well. How do they say? Somebody said, fools learn from their own mistakes, wise men learn from mistakes of others. So you're all wise men and women now. You have learned from my mistake, so that when you get this, you can do that. Right, now final instructions when it comes to cranial nerve examination. Now, when you examine and find some cranial nerves are diseased, it is very important to look at neighboring cranial nerves. You have to keep going up till you find a normal cranial nerve. Keep going down till you find a normal cranial nerve, so that you immediately localize the extent of damage. For instance, if you find a patient with 7th nerve palsy, it is very important to check for the 6th nerve of the patient, because if the 6th nerve is normal, you know that, okay, above this is normal, above 7 is normal. So you go down, go to the 8th, listen to check the hearing. And if that is also normal, you know that this disease is confined to the pons and it is affecting only the 7th nerve. But if the 6th nerve was indeed diseased, then you need to go to the 5th nerve to see whether that is damaged. So you go up till you find a normal cranial nerve. You go down till you find a normal cranial nerve, so that you will find exact the length of the brainstem which has been affected. So that's step number 1. Step number 2, after all cranial nerves, you must check the upper and the lower limbs. You don't have to do much. You don't have to do a full exam. Just tap on the bicep reflex and the knee jerk. Check on the knee jerk, just to make sure that the pyramidal tracts, which also traverse the brainstem, have not been affected by this whatever condition which is affecting the cranial nerves. Now, we know for sure, if by any chance the patient has had a stroke, upper motor neuron facial nerve palsy, then of course, obviously the lower limbs and the upper limbs will have exaggerated reflexes. If it is even a brainstem stroke affecting the facial nerve nucleus, there can be opposite side, upper limb and lower limb reflexes exaggerated. But even with other cranial nerves, second step is always to tap on the biceps and tap on the knee to look for exaggerated reflexes. Third step you need to do is look for an intention tremor to look for cerebellar affliction. Remember, all 3 parts of the brainstem are connected to the cerebellum through 3 cerebellar peduncles. So any cranial nerve can involve the cerebellum as well. So the third thing is to look for cerebellar diseases. So the 3 things are, 1 is go up and down the cranial nerves till you find normal cranials up and down. 2, examine the upper limbs and the lower limbs with reflexes very quickly to make sure that the pyramidal tracts are not affected. 3, examine for intention tremor to make sure that the cerebellum is not affected. And of course, the 4th, if you can remember, look behind the ear for a VP shunt tube. Because if the patient has had, say, raised intracranial pressure due to some reason, then you know for sure that the VP shunt, if you see that, that will be an important finding. VP shunts are behind the ear, and it comes from behind the ear and it enters the thorax. You know, it traverses the neck and then it enters the thorax. The other thing which can look like a VP shunt is a thickened, is it a great auricular nerve? Yes. Thickened nerves can look like VP shunts. Of course, VP shunt tubes are much bigger and more rounded. So the 4th thing, if you remember, will be after you do the cranial nerve examination to look for the 4th one, VP shunt. So in summary, that's the final instruction is go up and down cranial nerves, look for upper limbs reflexes, lower limb reflexes, and then look for cerebellar intention tremor, and then look for a VP shunt. Right. So that brings me, I think, to the close of my presentation. So if I were to very quickly summarize for you what I've been speaking about, first thing is to know that unlike the heart and the lungs and the abdomen, nervous system has 3 short phases embedded in that. You need to prepare separately for 3. Face, upper limbs, lower limbs. Second thing is to know how the marks are distributed. 30 for examination, all items and correct technique. 30 for detection of normal physical signs. 30 for discussion, which will revolve around diagnosis, differential diagnosis, and possible investigations. And 10 marks for the general approach to the patient on how clearly you speak, how confidently you speak, and how you handle the patient if you're good to the patient, etc. So the mark distribution may slightly change in different faculties, but this is roughly the same for the MBBS and the MD all. Then I looked at the examination, what are the commands that you might get. You might get upper motor cranial nerve examination, lower motor cranial nerve examination, motor cranial nerve examination, or inspect the face and proceed. Maybe speak to the patient and do the needful. And then I spoke about inspect the face and proceed. Under that, I spoke about unilateral ptosis, a bilateral ptosis, open eyes with a convergent squint, the 6th nerve palsy, then a facial loss of facial muscular power, which will look as if less prominent nasolabial folds and a non-blinking eye. Yes, those are the ones that I said you need to, or you might see if you are given the command of inspecting the face and proceed. The danger about inspect the face and proceed is you need to very quickly gauge what are they talking about, which of the stuff that I have spoken to you about is the one this case is all about. And once you finish all that, the next step will be for you to examine the cranial nerves, keep going up and down, and then do the upper and lower limbs, the jerks, and then do the cerebellum. And if you can remember, look for a VP shunt tube behind the ear. Right, Chamara and Dhammika, if you are still there, I've finished my little bit. I'll be happy to take any questions, which I hope this has been of some use to the audience. I would value to know what they think about this as well. And then, of course, I'll be happy to take questions. Yes. Chamara?
Yes, sir. And thank you very much, sir. That was a very fascinating talk. And I'm sure that's an eye-opener for all the students. And this is what clinical medicine is all about. And I must tell you, sir, today we had the highest participation. So we had more than 400 medical students joining through Zoom, and probably had an equal number joining through the Facebook Live as well, sir. So that's a record to start with. So thank you very much.
I hope they have not wasted their time.
No, not at all, sir. And actually, there are a few questions in the chat box, sir. So I will just
yes.
You
can read them out for me, please.
Yes, right. So the first question is, do we have to check the vestibular part of the 8th cranial nerve in a short case?
Because as I told you, we are trying to sort this thing out within 4 minutes, maximum 5 minutes. And we know that the candidate has to do a fair amount of things when it comes to cranial nerve examination. So vestibular part will not, I mean, at least I have never tested that, and I've never seen that being tested in any undergraduate exam. Chamara, I don't know, I would value your input. Have you ever seen that happen?
No, sir. No.
Now, Dhammika, are you there? Dhammika Palankasinghe, I don't know if you're there. I've never seen, so don't worry about it. Don't waste time. Just be very focused on simple things, because at the end of the day, what a medical student must understand is how will the examiners give you marks. They are not trying to see whether you are a good consultant or whether you're going to be a great consultant or a great registrar. They just want to see whether you are a safe house officer who knows to do the basic things right. So if you can do the basic things right, that is more than sufficient for an undergraduate. No worries. Just do the listening part of it. That's enough. Okay.
Right. Okay. The second question is, are we supposed to check the pupils and fields in motor cranial nerve examination?
In motor cranial nerve examination, the thing is, now, what did you want to do? Visual fields and what is the other one?
The pupils.
The pupils. Right. It's like this. Now, visual, obviously, we have to check fields, etc. Because when you are examining, if the patient can't see, for instance, if the patient has a homonymous hemianopia, he will not be able to see the finger. And without seeing the finger, he will not be able to move the eyes. So, and also, I suppose you can avoid pupils. Yes. But what I would suggest is have examination of the eyes protocol well ingrained. Once you are well ingrained, maybe yes, motor cranial nerves, you can probably take away the pupils. But thing is, now if you are dealing with say ophthalmoplegia, I think it is very useful to know what the pupils look like. I mean, if the pupil is dilated and you are seeing some kind of squint, then that part comes part of the motor. It is useful. So yes, you will not be penalized for not checking pupils, but what I suggest is you just have this well ingrained protocol for the examination of the eyes, and you do it very quickly and finish off so that you have covered 3, 4, and 6 straight away. But without the patient seeing, I mean, I know that 2 is a sensory nerve, but without the patient being able to see, he will not be able to move his eyes. So trying to differentiate what is sensory, what is motor within the eye may not be very simple. Quickly do everything and finish off the eyes, and then get 7 and do the 9 and 10 together, 11 and 12. That's how I would approach. I mean, the thing is, Chamar, I think I would value your opinion. I mean, I don't think you have time to think in the short case, really, really think and take, this I should do, this I should not do. It just examination just comes automatically. You just pick up the signs and then you discuss what you've seen.
Yes, that's true, sir. Yeah. And then there's one other question. In a hemiplegic patient, if the face is not involved, how to check at which level the lesion is? And if the face is involved, how to check where the lesion is? So I think, yeah, the question is about hemiplegic patient with the face involvement.
Okay, that's not part of this lecture because we are trying to look at the face which is involved. So you're talking about an upper limb examination or a lower limb examination. So if the patient has arm and leg weakness, there are only three places that people can have a stroke. One is within the cerebral cortex. Now, if it's a cerebral cortex, that should be, it should be face, arm, leg weakness. But of course, you can have facial sparing if it's in the cerebral cortex, because cerebral cortex is a large area and you can get a smaller area affected and actually face can be spared. But if it's internal capsule, definitely the face will be gone. Definitely face, arm, leg weakness. So, and then of course, brain stem, somebody can theoretically argue saying that if there is a stroke above the facial nucleus, and they can get arm and leg weakness, but it may not manifest itself. So I don't think you need to really worry too much if the arm and the leg is weak. You just say that the patient has had a stroke, very likely to be cerebral cortex, because again, even if in the internal capsule, it is possible, though all the fibers are very compactly packed, it is possible theoretically for the face to be spared. But face to be spared is much more likely in a cerebral cortex rather than anything else. If it's brain stem above the facial nucleus, some other cranial nerve has to be diseased, some other cranial. So if all the cranial nerves are normal, then it is likely to be cerebral cortex rather than the internal capsule. But again, now don't worry too much about the level. All you can say is if the arm and the leg are gone, then arm muscle, it starts with about C4, we're starting about C4, or at least C5 will be start. So it's above C5. As long as you say above C5, I think that will be taken as being reasonably okay. But let's talk about upper limbs and lower limbs on another day, maybe another teacher. Okay. By the way, if you all want, if you all can locate the SLMA talk on lower limb examination, I don't know, it must be available somewhere as one of the Saturday talks last year. It happened, one of the first few talks, you can learn about lower limbs. Right, Chamar, anything else?
Yes, so there's one other question about, you said we should check one nerve above and one nerve below to localize. So if the instruction is to examine the upper cranial nerves and there is a defect in 6th cranial nerve, is it okay to check 7th also?
Well, if you are specifically told to examine the upper cranial nerves, stick to that and finish. Stick to that and finish, because your defense is you are asked to do only that. But if you have time, better to look for the 7th nerve. And if the examiner asks, you just say, I know that the 6th is gone, so I just want to check whether the 7th is okay. But even if you don't check the 7th, if you've been specifically told upper cranial nerves, it's okay to stop there. General principle is, if possible, if you have time, everything is if you have time, it's good to go up and down till you find the normal one.
Right. Okay. Thank you, sir. And then there have a few questions with regard to, yes, so they are probably for me because this video will get uploaded to YouTube. So you can watch that leisurely as well. There have a few questions asking some explanations because there were some connection errors and all that. So hopefully you can access the video shortly. We will upload it to the SLCIM YouTube channel. So I think with the interest of time, sir, I think yes, so we'll end the Q&A session. And let me thank Professor Arosha Dissanayake, Professor in Medicine, University of Ruhuna, for that superb lecture and for spending your valuable time on this activity. And also, I would like to thank the President, Sri Lanka College of Internal Medicine, Dr. Kumudini Jayasinghe, and my Joint Secretary, Dr. Kawalitha Jayasundara, for all the support on this activity. And also Dr. Ganaka Senaratne, our immediate past president, and Professor Tilak Chailath for their continuous guidance and support on making this event a success. And also I extend my thanks to all the deans of the faculties of medicine, all faculty representatives for the permission granted and for coordinating this at the faculty level. And also I must mention Mr. Dishan Fernando and Jets Pharma for its technical support and providing the Zoom platform for this activity. And finally, dear students, so those who have joined today, I think we had a very high number today. So without you, this wouldn't be a reality. So thank you very much. So let's meet again in the month of March with another interesting topic and a great teacher. So have a very pleasant evening. Thank you very much. Thank you, sir.
Chamara. Thank you for all the effort in organizing this. I'm most grateful. I hope you'll be sending some feedback form, so that might help us identify further areas to improve. Thank you so much. Have a pleasant evening all.
Thank you, sir.